Dr. Ragini is asking for faculty link.
उनको पास है
Already
वशिष्ठ
sent her.
आपने भेजा
ग्रुप में डाला है।
सबको भेजा है फैकल्टी लिंक।
उन्होंने ग्रुप में
साधना,
डाला है।
तुमसे मैंने डेलीगेट लिंक भी ली थी।
हाँ
मेरे
हाँ
कई सारे पोस्ट ग्रेजुएट ज्वाइन करना चाहते थे, तो आई थिंक
वो मैडम एक्टिव है, संजय को भेजा है मैंने।
हाँ, मिल गई, लड़कियां सब
हाँ,
ज्वाइन कर रही होंगी सब।
हाँ संजय को भेजा है मैंने।
Ma'am, we are good to go. We are live now.
A very good evening to all the revered dignitaries, respected seniors, faculty, and dear friends. On behalf of North India Gynae Forum, I welcome you all to this unique webinar on preconception care and early maternal screening. NIGF is Dr. Sharda Jain's baby and is being led by a very great leader, Dr. Sadhana Gupta. This is the third of the academic series of NIGF, and previously we had two important sessions that was on role and responsibility of gynecologists in independent India, which was the oration given by none other than Tamal Bakshi, and the other one was adolescent PCOS, beware and be aware, which was delivered by Dr. Sadhana Gupta herself. So this webinar of today is focused on reducing the morbidity and mortality of patient and the fetus. So to begin, I will request Mr. Vashish to begin this webinar with lamp lighting and invoking Lord Ganesha and taking his wishes. And I request all the dignitaries on the dais and the attendees to please join us for this prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
As I already said that NIGF is Dr. Sharda Jain's baby, and Madam is a selfless leader and a gynecologist par excellence. And we are fortunate to have Dr. Sadhana Gupta as the president of NIGF, the lady with vision. Her righteousness, dedication, and depth of knowledge is, I mean, we cannot compare that. There's no competition here. And now I invite Sadhana Gupta ma'am to invite and welcome the delegates and our guests, to introduce our guests who are the top and the most admired gynecologists of North India. Over to you, Sadhana ma'am.
Thank you, Amrita. And it is indeed a moment of privilege while I welcome in the capacity of President North India Gynae Forum to the third Academia series, which is organized under aegis of NIGF. So North India Gynae Forum, a small word about it, that it has been framed and founded with the aim to connect all obstetrician and gynecologists of 7 states of North India. We are slowly taking steps that we handhold each other, we give platform, and we bring up the talent of OB-GYN of North India, right from elder mentor teachers to youngsters. And what is the aim? Actually, the best thing which we can give to anybody is the self-confidence. And NIGF is found with the vision and mission to give self-confidence to every OB-GYN, whether it is in any state or any hook and nook or corner of the North India. So North India, it is spread all over the mountains. We have Ganga, Yamuna, we have the prime peak institution, public health institution, around 6 AIMS, public health sector, a very well built up private sector. And we need to bring up, we need to connect, we need to share and teach and learn expertise and what is expectation. What Dr. Kamal Bakshi's oration last on the 15th August, that what we are supposed to do as an obstetrician and gynae in making up of independent India. So it is a very small beginning, but it will be having a great future, what we see. And it is our real pride and pleasure to have none other than Dr. Chandravati to bless this webinar at NIGF. Please, Bashish, share Madam CV. Dr. Chandravati is a person, actually what we say, what we are, I am today, I personally owe to Dr. Chandravati, Madam, because when she organized in 1999 AICOG, that was the first managing committee meeting I held, and like I came to know what a professional body should have and what a professional body can have. So Madam Chandravati is a person who generously provides peaceful shelter where anyone can be nurtured, everyone can grow without worries and apprehension. Her birthplace is the city of Varanasi. She was a student from KG Medical College, and right from student to the young doctor, and became head of the department in Obs-Gynae, and she is emeritus professor in Queen Mary Medical College. She has been the landmark chairperson because she is the only person who has organized 1999 AICOG and 2020 AICOG as a chairperson. She has been conferred Commonwealth Fellowship, Best and Teachers of Teachers Award, Saraswati and Mahila Shakti Award, and Grace position of President UPCOG, Vice President Foxy, and President and Patron of LOGS. So we are really honored to have you, Madam, and these are few photographs of her life, and which shows like a journey from a young student to today what she is. So Madam Chandravati, please, we welcome you for your blessings and for your address.
Thank you, Sadhana. I think I was really shocked to see one of my very laughing photograph over there, because I don't know when you got that photograph and how you got it. इतने सारे उसने कसीदे मेरी तारीफ में पढ़ दिए. I don't think that much I deserve. It is always a pleasure to see your youngsters, your children growing and doing so well. And it is always a pleasure to see Sadhana. You know, first time I met her during my 99 conference, and I was really happy to see a girl who could talk in the managing committee meeting and bring out points there in the managing committee. And then I tried to find out her name, and that was my first knowledge about Sadhana. And then from that day onwards, I kept on meeting her. Many times we stayed Gorakhpur, and it had been always a pleasure trip combined with academic sessions. It is really amazing the way Sharda and Sadhana have worked together and really united the whole north of India and bringing us all together under this forum. Thank you, Sharda, for really bringing it out. Initially, I was really not very, because I'm one person who don't read too much of WhatsApp and other things. And many times only through phone and all that, I get that knowledge. But right now, today, I'm proud. And I'm really very, very proud to have Sharda to start this initiative and Sadhana to manage this big forum. I will be always there till I am useful to you all. My blessings are always with you. Whenever you give me some job, I will be there to do it to my utmost capacity. Wishing you all a luck for all the coming events, and wishing you a very successful webinar today, because all the topics you have chosen is dealing with the maternal health and decrease the maternal neonatal mortality, and that is aim of each gynecologist who is working in this country. So I wish you all success. I'll be there for some time with you and hope I'll be there in the next webinar as well. And thank you again, Sharda, Sadhna, and all members of this forum. Thank you.
Thank you, madam, for your gracious present and words of inspiration. Thank you, madam. And it is, again, we are really privileged to have Dr. Sushma Chawla, who is with us to bless NIGF and this webinar. Dr. Sushma Chawla is a known person. She is a laparoscopist, endoscopist, and then been honorary professor ICMCH, and she is from Punjab. She has been the founder chapter secretary of IMS and Club 35 Jalandhar chapter, president Narchi Jalandhar branch, president Rotary and the IMA Jalandhar, and she has been member of Juvenile Justice Board and the member of Child Care Committee. She has been awarded with many awards, and she has organized many academic programs. A very senior person. Dr. Chawla, we request you to say few words and give your blessing and your views about the program and the NIGF. Unmute yourself.
Ma'am, unmute yourself. Dr. Chawla, please unmute yourself.
You are muted.
नेटवर्क चला गया क्या उनका? क्योंकि पिक्चर भी चली गई है।
Still हो गया।
लग रहा है ना मैडम का?
Still भी हो गया।
हाँ, still हो गया।
तुम लोग चालू कर दो, जब वो आ जाएंगे तो फिर ज्वाइन करा लेना।
Yes.
Okay. Thank you, Chandravati madam and Sushma Chawla madam for your gracious presence. And Chandravati ma'am, you said that you don't deserve. I think you deserve much more applaud and much more appreciation. We don't have words for you. And we will wait for Sushma ma'am's blessings. And moving forwards, thank you, Sada ma'am, for your inaugural speech. And we all know that the preconception care is individualized care for people considering pregnancy. And in this period, risk assessment, health promotion, and medical and psychological interventions are very, very important. Also, the lifestyle is very important. So over to my co-convener, Dr. Pooja Jain, for the further proceedings and for the first session. Over to you, Pooja.
Thank you, Amrita ma'am. So let us start with the first session of today, the keynote address, the topic of which is preconceptional care. And I would hereby request Dr. Achla Batra ma'am, who is the speaker of today's program. Madam is well known to me. She is from my parent college. I have had the opportunity to have all the things that I know from Obs and Gynae from her. She is presently a consultant at Mata Gurjari Hospital, Delhi. She had been an ex-professor at Safdarjung Hospital. She had been president of AOGD and NARCHI. And she has reviewed multiple national journals and authored articles, and she had been a co-investigator in LSTM project. And she has been a WHO Saver Project Master Trainer in 2021. Welcome, Professor Achla Batra ma'am. We love you, ma'am. And the experts for today's topics are starting with Dr. Shyamyari Jaiswal. Madam, welcome as an expert to the topic of the keynote address today. Dr. Jaiswal is professor and head of Obs and Gynae in KGMU Lucknow. Ma'am has received so many awards and prizes like Chandravati Devi Jagannath Singh Prize. In 2017, ma'am had been president of Lucknow Obs and Gynae Society. She had been president of ISOPAB Lucknow branch. She has served as vice president and secretary of LOGS. And she's received multiple paper and prizes and trophies. So ma'am, please welcome on board as the expert today. The second expert for today is Dr. Vidhu Mudgil. Dr. Vidhu Mudgil is consultant and director of Suman Hospital and New Life Infertility Research Center at Ludhiana. She had organized North Zone Yuva Foxy in 2022. She has been president and secretary of Ludhiana Obs and Gynae Society. She is a member of Food and Drug Committee and Perinatal Committee, and she has received multiple awards in national and international conferences. Welcome, Dr. Vidhu.
Thank you, dear. Thank you.
The third expert of today is Dr. Pushpa Setish. Madam is a senior practicing obs and gynae at Gurgaon. She's the director of Sethi Hospital. She's the president currently of Indian Menopause Society. She had been the organizing chairperson of IMS Fund 200 in 2018. And she's the chairperson of Midlife Management Committee Foxy, past president of IMA Gurgaon, and recipient of Lifetime Achievement Award by IMA Gurgaon. Welcome, Dr. Pushpa. And last but not the least, our dear Kishore sir from Delhi, who we all know as, he had been the HOD of Obs and Gynae at Sanjay Gandhi Memorial Hospital. Sir had been a DNB, National DNB Examiner and Honorary Finance Secretary of IMA DNZ and chairperson of PCP-NDT Delhi. Sir has received APJ Abdul Kalam Excellence Award from DGF, and he had been the president of DGF Outer Delhi also. Welcome, sir. So now handing over the mic to Dr. Achla Batra. Madam, please start the session.
Thank you, Pooja. Thank you so much. And I feel really honored and privileged that I'm speaking in front of such a forum, which is so prestigious, North India Gynae Forum. It has been an historic event that we have made this forum this year under guidance of Dr. Sharda Jain. I feel humbled that I have people like Dr. Chandravati and Dr. Sushma Ravla to listen to me, and of course Dr. Sharda Jain ma'am. And in fact, I seem to know everybody who is there, Dr. Kishore, Dr. Kanchan, Dr. Alok and Vidhu. We just met her in Ludhiana, and Dr. Jaiswar I just met in Lucknow. So it's really nice to be among friends and be, talking in front of all of the North India Gynae Forum, which is, something we must all propagate. Those who are members, fine. Those who are not, they should become if they are in this webinar. And those who are already members, they should tell others to become members, because North has so much, academia. We have, said, we had AIMS, we have so many people who are doing such good work, and we have to shine and make it the most shining star of our nation, and then maybe, go forward from there. So now I begin my session on preconceptional care. So what is preconceptional care? If you define it, it is the provision of biomedical, behavior, and social health interventions to women and couple before conception occurs. And what are the goals? That we have to identify potential risk factors through the mother, fetus, and to pregnancy itself. And then educate the individual about these risk options for intervention and management for risk reduction and reproductive alternatives. And so that we can optimize maternal and fetal and pregnancy outcomes, and wherever required, do specialist referral. But does it happen? We all talk about preconceptional care, but in India, what we see is when we give care is when the patient comes to us pregnant. If you see that 40% of the pregnancies are unplanned, iron deficiency anemia is present 60% to 70% women, and is responsible for 20% of maternal mortality. And this data is from WHO, and they have said that 58,000 newborn in world, they die from tetanus. And we don't have it so much, but female genital mutilation also increases the neonatal deaths and stillbirth. Very many young girls become pregnant, and the perinatal death is total perinatal, 50% is because of this pregnancy in these adolescent women. And we have untreated STDs, which are responsible for 10% of perinatal death. HIV transmission increases from 15 to 45% if you don't intervene. And when there is violence, sexual, physical violence against girls, the consequences are on the mental health, and which leads to premature deliveries, low birth weights. Then we have many, many medical illness like epilepsy or other illness also. The drugs for the illness or the illness itself may be exacerbated during pregnancy. And if the woman is, you are saying first time in pregnancy, your chances to do much are reduced. So, and the growing pandemic of alcohol, smoking, and substance abuse is also responsible for much of the. So what is our role in it? Now we have, we feel very proud that we had decreased our maternal mortality. But what further we can do is, now it is the time that we come to maternal and child health by prevention of all the problems which occurs during pregnancy by the preconception care. And preconception care is not something you give when a couple or a woman comes to you wanting to become pregnant. Preconception care is something we have to give to a woman at all points of contacts, whether it is an adolescent girl or a woman coming for discharge PV, or she's come because she thinks she's pregnant and she's not, or she's come for contraception, she doesn't want to be pregnant. The preconception care has to be given to her so that the preconceptional health is good. There are two components of preconceptional health. First, the pregnancy has to be planned. The couple should be enabled to choose when they want to have pregnancy. And second is fitness for the pregnancy should be there so that they have a good. So what will it do? It will reduce all the things we talked about: maternal and child mortality, unintended pregnancy, complications, stillbirth, preterm, low birth weight, defects, birth defects, infection, underweight, stunting, vertical transmission of many diseases, diabetes, cardiovascular disease later in life. It's not that the concept of preconceptional there was not there earlier. It has been there from time immemorial. In the Western literatures, we say the Pluto has written that the woman should exercise so that she has strong and healthy bodies. In the Old Testament, they say that the woman should stop drinking wine or strong drinks so that they can healthy baby. Even our Indian literature says, it is there in the Garbhadan Vidhi that the age of the male should be 25, they should not be consanguinity, they should not be suffering from any sexually transmitted disease. And Ayurveda talks of care of the physical, psychological, and consciousness before the couple decides to become pregnant. And of course, it has to be done before pregnancy. And like I said, it is not any 1.3 months, 6 months, or 2 years before the couple is planning pregnancy. It should be done at every point of contact. So in England, they have defined, the pathways to preconception care is prior to first pregnancy, and then pathway to what we normally most of us understand, that targeted preconceptional care. When a couple is coming to you that they want to become pregnant, then targeted intervention are there. And then after pregnancy also, you have to have interconceptional care, which will include the universal preconception and the targeted. So what is pathway one? Pathway one is, it starts in utero actually. We know now the epigenetic origin of disease. If the baby is FGR or baby is too large, this baby is going to become diabetic later in life or may have mental problems because it is too small. So from that time onward, the preconception take off. And the school age, the child should be healthy, not anemic, not having infestation, not having any mental problems. The adolescent health is the most important part of preconceptional care. They are the building blocks of our nature, and the adolescent's health has to be taken care of. And of course, in adulthood also, you have to take care. Then we have the pathway 2, which is very targeted, that what age they should become pregnant, what vaccination they should take, what diseases is there, what care should be taken. And third is, like I said, the next baby and beyond, when whatever happened in previous pregnancy may impact their future pregnancy outcome, plus the universal care. So in 2013, WHO had a meeting in New Delhi in which they, because at that time also in Western world, there were packages of preconception care, but not in the Eastern world. And they thought that you can't deliver it, just before pregnancy. They divided it into two phases, that healthy transition for adolescent and a pre-pregnancy, which translates into the universal package or pathway 1 and pre-pregnancy care package pathway 2. So what is we have to do for adolescent? We have to teach them to have a healthy lifestyle, do exercise, diet, weight management. They have to have sexuality education. They have to be taught about STD, how to prevent it. We have to look after their social and mental health, prevent addiction in them, treat it, give them whatever vaccination is required. They have to be given information about contraception and avoidance of unwanted pregnancy, and of course, nutritional education and anemia prevention, which is so common in our country. So, but when we come to targeted care, then whenever you are planning to give a preconceptional care, you should have a checklist. And we'll talk about all these sectors one by one, that what is the age, weight, nutrition, anemia, addiction, mental health, medical disorder, drugs, infectious disease, STD, vaccination, environmental and genetic disorder. This checklist, everything has to be talked about. Patients have to be given information about contraception so that they plan a pregnancy, because unplanned pregnancy most of the time result in abortion, which may be safe or unsafe. And even if a child is born of an unplanned pregnancy, that child is sometimes not taken care of. Then age, we have to know. The age has to be proper. Best is between 20 to 35. If they have a teenage pregnancy, they can have eclampsia, preeclampsia, preterm labor, low birth weight, stillbirth, neonatal deaths, increased perinatal death. And you can see, the best time is between 20 to 35. If they become pregnant late, they'll have declining fertility, miscarriage, chromosomal abnormalities, GDM, hypertensive complication, and stillbirth. The weight management, which has become an epidemic nowadays. Everybody is obese, starting from adolescent, and they become pregnant and they are obese. And all the pregnancy, if they are morbidly obese, they can have, neural tube defect, macroscopic baby, GDM, stillbirth, hypertensive, and so on. So they have to be told that this all has to be managed before they become pregnant. And sometimes they are so obese that we cannot even control them after the counseling session and the diet and exercise. And these are the women who might need bariatric surgeries. And who are the ones who will need? Who have weight of more than 32.5 kg per meter square BMI with comorbidity. And if it is 37.5 without comorbidities, they should be advised the surgery, and then they have to wait for 12 months after the surgery. Underweight, of course, have to be given the nutritional advice, because they can also have problems of preterm, low birth, and some birth defects. And they also have to be screened for psychotic disorders like anorexia nervosa and bulimia. And of course, at that time, again, the importance of healthy diet, exercise, and safe sexual behavior and practice has to be given. In the diet, they have to be told that, because today's the corporate world, the girls are sitting in front of their computer working and drinking coffee, tea, and it can increase the risk of miscarriage, congenital malformation, growth restrictions, stillbirth, and also behavioral fate. So therefore, and we also must know, there is in some communities, they give a lot of fish during pregnancy. So uncooked fish should be avoided. And certain quantity of certain fish, they have a lot of mercury in it. They should be avoided. Then another problem is substance abuse. They have to be screened for these abuses and counseled about the effect of smoking, which can lead to birth defects, heart defect, musculoskeletal defect, gastrointestinal defect, miscarriage, preterm, low birth weight, fetal growth restrictions, stillbirth, and sudden infant death. Heavy alcohol can increase low birth weight, small for gestational age, preterm, and binge drinking may affect neurodevelopment outcomes. And of course, the substance abuse can cause all these problems. miscarriage, preterm labor, and also infections because they're using syringes, HIV, hepatitis B, hepatitis C may increase. So what we can do? They have to be just told, we have to educate them that if they don't stop, how will it affect the baby? And once they stop it, they have to wait for 6 months before they plan pregnancy. Anemia, we all know, which is a universal problem, not only in India, all over the world. So everybody has to be screened for anemia, and it has to be treated. The government recommend 100 milligram of elemental iron and 500 microgram folic acid should be given before 3 months before preconception. They can start. Then we have folic acid supplementation. Though we all give folic acid, but we have to recognize people who are at risk for NTD. If there is a family history of neural tube defect, or there is maternal diabetes or malabsorption syndrome, and high risk in which the woman or their partner, they had NTD, or they had NTD in the previous pregnancy, if they have hemolytic anemia, increased BMI, they have MTHFR mutation, hemoglobinopathy, or they taking some drugs which affect folate. So you have to tell them that they have to take extra folic acid. Moderate risk have to take 1 milligram, and severe high risk have to take 4 milligram at least 3 months before they plan pregnancy. Then we have infectious disease, like we said, HIV, syphilis, hepatitis B, which can cause, infertility. They may not conceive, and HIV may be transmitted to the baby. Hepatitis B may be transmitted to baby. So they have to be treated. Hepatitis B and HIV, syphilis, all they are treatable disease, but we have to screen them and treat them. Then we have maternal mortal illness, which is, a great part of preconceptional care, because the disease has to be optimized, the treatment compliance has to be ensured, and certain medication, and we have to see whether they will be able to do whatever we tell them. That social support has to be ensured. So we have hypertension. Everybody we do it is screened for hypertension, and the cause of hypertension may be autoimmune disorders or renal disease, because hypertension, we all know how it is associated with different impact on the fetus as well as the mother. And of course, we should know that the BP has to be controlled to 140/90 before the woman embarks on pregnancy, if she has any end organ disorder, and be at least 150/100 if we are not able to control it. But above that, she should not conceive. Then diabetes, you all know, we all screen with the 75 gram OGTT in pregnancy. But before pregnancy, we have to know whether she's diabetic or not, either by hemoglobin A1C or a fasting or PP. And we all know the risk of diabetes, and patient has to be told. And if she is already diabetic, then you have to see that her hemoglobin A1C is less than 6.5. She knows how to do self-management of diabetes, and importance of good control has to be told to her, telling her about the risk of anomalies in a pre-existing diabetes. The risk of anomaly is not there in GDM, which occurs during pregnancy, but those who have it, they have to control and make the hemoglobin A1C less than 6.5. Hypothyroidism, now we are doing universal screening wherever it is not possible, targeted screening in area where there is iodine deficiency, there is a family or personal history of diabetes or history of miscarriage, preterm delivery, or morbid obesity is there, hypothyroidism must be screened for. And we all know it is associated. So patient has to be told that if she doesn't control, we have seen, patients are taking treatment for hypothyroidism. When it becomes normal, they think now they are okay. They have been cured of the disease. They have to be told that hypothyroidism is not a disease. It is a deficiency which is going to stay with them, and it has to be, the supplementation has to be taken. And of course, early identification, and if already on drugs, then we have to increase the dose by around 30% at time of pregnancy confirmation. We know have to treat overt hypothyroidism with low FT4 level, even if the TSH is between 2 to 5.3. And if TSH is more than 10, Irrespective of FT4 levels, we have to treat. Rest of the woman, we have to refer. Hyperthyroidism is very important. No, not so common, but we have to know that if woman is planning pregnancy, then she should be treated with surgery if it is an option, because radioactive iodine is not good in the pre-pregnancy. And if she is using radioactive, it has to be used, then she has to wait for 6 months after the stop of treatment. And for anti-thyroid drugs, she has to be put on propyl thiazole, because in first trimester, we don't want her to be on methimazole, which has embryopathic effect. Autoimmune disorders, we have to know that they can be exacerbated during pregnancy, and they can have preeclampsia. So we have to, keep a look out for them. And the drugs which are teratogenic, like methotrexate, should be discontinued when patient is planning pregnancy for at least 6 months, and patient should be disease-free for 6 months before she plans pregnancy. Heart disease, patient has to be evaluated for any heart lesion, because it comes as a surprise to us many times during pregnancy that patient has a heart disease, and she has to be consulted about contraindication to pregnancy, like severe pulmonary hypertension, ventricular dysfunction, NYHI 3-4, left ventricle ejection fraction less than or equal to 40 millimeter, aortic dilatation more than 50 millimeter, or there is severe coarctation. We have to tell them that they should not conceive, because it is going to be, can result in mortality for the woman. And the people who have heart disease sometimes are taking drugs, especially if they have had mechanical valves. So if they are already taking acetrom, then it has to be changed to heparin, because there is a risk of fetal embryopathy in first trimester with heparin, warfarin, which can be changed, of course, later on in second trimester again to acetrom, and then near term again to heparin. Seizure disorders, we must ask, because it is quite common in our country, and some of the drugs like valproic acid have increased risk of noodle tube defect and craniofacial defects. And it is better if she's taking many drugs, she should be put on monotherapy, but whatever she is controlled on, it is better not to change unless it is valproate. Also, sometimes you might have to continue valproate if her fits are uncontrollable, but before she planned pregnancy, for at least 6 months, she should be controlled. And of course, these women who are taking phenytoin, which are enzyme inducer, they will need higher dose of folic acid supplements. And if they are taking contraceptive pills, then they have to be told about the risk of contraception failure with low dose OCPs. Thrombophilia screening only if there's a family history or a past history is there. And these women are, of course, are at increased risk of preeclampsia, abruption, IUGR, pregnancy loss, and they have to be treated with anticoagulants during and after pregnancy for long term. Then we have renal disease. It has to be controlled if they want to become pregnant. The creatinine should be less than 3 and the nitrogen less than 30 milligram. And if somebody has had a renal transplant, which is becoming very common, and they want to have pregnancy, it should be avoided at least for 2 years. Infectious disease, we already talked about. Dental disorders, again, is something which is neglected, because we did a study in our hospital. We found that these women who have periodontal disease or caries, they have higher incidence of preterm labor and prompt. So must ask a woman, and if she has any dental problem, let it be treated before she becomes. Vaccination, very important. Vaccination should be done before she becomes pregnant. If she's not vaccinated for hepatitis B, if not measles, mumps, but at least rubella, IgG should be done. And if she is not immune, she should be given vaccination. Tdap, we give it in pregnancy, that is more useful. And HPV, and nowadays even the COVID vaccine, we want to give it before she tries to conceive. Chickenpox, maybe if one is ready, one can have a chicken pox vaccine if they have not had chicken pox in childhood. And in the area or in the season when influenza is rampant, influenza vaccine is not a bad idea. And if we don't vaccinate them, then they will have hepatitis B infection, which can be transmitted to the child, who can then later have childhood cancer. So this is a very important intervention we should do. And the live attenuated vaccines should be given at least 3 months for whatever reason. If they have to take for going abroad or whatever, they should be taken after taking those live vaccines. 3 months pregnancy should not be attempted. Psychosocial disorder should be identified and treated, because it can really lead to problem for the mother as well as for the baby. And sometimes the drugs which are already being used for these psychiatric diseases can affect the baby. So they have to be referred to a psychologist, psychiatrist to change their drugs. And ideally, it should be discontinued, but sometimes it is not possible. Then you have somebody who has, suicidal ideation, or then they have to be continued, explaining then the risk benefit. Then the very important is genetics. A very good history, 3-generation family history should be taken to avoid all these things. We have to take history of consanguinity. We have to take the history of hereditary disease in the patient or the family member, multiple family member with the same disorder, advanced age, terogen exposure, ethnic, like we have a lot of thalassemia. So we should be screening. I think we should be screening everybody for thalassemia, and Down syndrome in the previous baby which is there, or recurrent pregnancy loss, family history of early onset cancer is there. And if there is a non-malignant disorder which has come very early, which is not really expected, they should also have genetic screening. Environment has become a very important factor nowadays. They have to be told that if they are exposed to chemical, physical, or biological hazard like lead or other toxin, or if they have hobbies in which lead is used, or the lead glazed dinnerware is used at home, they have to be careful. If they're taking it is better that they should be boiling this water, because they can be exposed to nitrates, mercury from fish, I've already told. So preconceptional counseling and screening is a very important intervention which prepare the mothers physically, emotionally, so that they have a good outcome. Goal is to screen for risk factor, impart relevant counseling, and initiate intervention. So you have to have a checklist, take a thorough history, identifying the risk factors, and high risk history of genetic disorder is there. They should go for genetic counseling, and chronic medical elements should be optimized before they embark in pregnancy. And the intervention which can reduce the occurrence of congenital abnormalities include folic acid supplementation, intake of good diet, glycemic control in diabetic, alcohol, illicit drug use, cessation, reduction of obesity, avoidance of teratogens, vaccination, behavioral changes, and risk of acquiring infections like toxop, cytomegalovirus, or sexually transmitted infection can be reduced. What is the take home? That preconceptional counseling does not start just before the pregnancy. It is the continuum of care from childhood to adulthood. And these gains which we build up in the childhood, they go on to adolescent, and then they become, they go on to adults and potentially parents. So like Nelson Mandela said, how we can do it? By education, which is the most powerful version by which we can change the world. It doesn't cost anything. You just have to talk about it. So what is the verdict? If we fail to provide necessary educational intervention in preconception period, then we are culpable, liable for preventive illness in the childhood and poor maternal outcome. So we should all gear up and do preconceptional counseling at all times of our interaction with an adolescent, a woman, a girl, so that we can, have a good maternal and fetal outcome. Thank you.
Thank you so much, Achla ma'am, for such a comprehensive and crisp guidelines about the preconceptional care. It is really an exhaustive topic and you've covered it so well. And now I would just like to invite our experts to have their inputs regarding the topic, starting from Dr. Kishore sir first.
Dr. Achila, congratulations for an excellent lecture. And actually, this topic itself is a neglected topic. It is never there in any of the conferences, and it is very rarely heard. So I was very happy that to be a chairperson for such a topic. And I think you have covered most of the things. And I just want to say that now we know now what are things to be seen, like
Sir, you've muted yourself.
Oh,
Sir,
sorry.
kindly
Okay, so was I heard? Yeah, I have to start from the beginning.
No, we
No,
heard
no, you
about
were heard.
the
You were heard.
Acha, acha, okay, sorry. So I just want to say that the dental part, I think, which is quite neglected by all of us before pregnancy. So that also that should be taken care, and the psychological aspects also. And in sometimes the patient is not willing for pregnancy, and the patient that pregnancy is forced or it is accidental in about 50% of American pregnancies are not planned. Similarly in India also. And the third thing is that the anemia, which is killing maternal mortality, I mean, such high, and that anemia is already there, and nobody is bothered. हम बाद में जब patient आता है antenatal में, then we are checking, अरे इसका तो HB कम है. So that thing, I think it should be monitored. And the folic acid, हम anti-NP करा रहे हैं, सब कुछ करा रहे हैं, but folic acid जो उसका treatment role है, वो 3 महीने पहले है. तो 3 महीने पहले तो nobody has started anything. So what is the use of that? And also I've seen the smoking and alcoholism is very, very common. It is increasing like anything. So how to tackle? I think there is a role of the adolescent clinics. Adolescent clinics का बहुत role है. At least in our institution there is an adolescent clinic, and I think that the prevention starts from there, not just before conception or when she is getting married or like that. And also the patients are getting married late. वो 35 में अब शादी करेंगे 38, and then they don't want to have children abhi, and they are waiting for that. All this, I think these are also part of our this prevention of aspect. And adolescent में acne होता है, acne में isotretinoin शुरू होता है कईयों का. That has to be stopped before at least 2 months before pregnancy. All these things are there. So therefore, I think our role is an education. When the patient comes to you, or uska koi adolescent is accompanying or something, that we have to, I mean, tell the patient or the mother or whose mother, that if they have an adolescent daughters, they should be, I mean, taught that, and including the vaccination, cervical cancer vaccination, all these things, plus, I mean, all other aspects of very nicely given by Dr. Achla. Thank you very much.
Thank you, Kishore sir. Now over to Dr. Pushpa Sethi, if you would like to just add and say something about it. Dr. Pushpa, are you there? I cannot see her. Then Dr. Vidhu Mudgil. Kindly unmute yourself, Dr. Vidhu.
Am I audible?
Yeah.
Yes,
Yeah.
you're audible.
So very well presented and a very relevant topic in at all the conferences. Yes, I think so. Antenatal, like preconceptional counseling is very, very important part, and antenatal care itself can bring down lots of issues in the maternal health. And as Dr. Achla has already mentioned, how preconceptional counseling and counseling of all the adolescents and the girls can help to take care of our health of our upcoming ladies, and their maternal outcome can be really, really changed. India still is till now fighting with anemia, although there are so many programs which are running to take care of anemia and everything. But still, I think so we need to work. अब हम देखते हैं OPDs में young girls आती हैं, mothers are always cribbing, खाती नहीं है, anemic है, ये, they have to be counseled again and again that the base is built now, so they can have a good life later on, and they can have a good healthy outcome as mothers also later on. So rightly put in all the words, and thank you once again for making me part of this webinar.
Thank you, Dr. Vidhu. Over to Dr. S.P. Jaiswal, ma'am, please.
Thank you, Pooja. I would like to congratulate Dr. Achla. You have covered all aspects. So many things we don't have in our mind. You have covered small bits of things. So definitely you have to be congratulated by this. And as Dr. Kishore said, definitely this is the neglected area where we don't talk much. And it is not only neglected area, it is a very important area also, because preconceptional counseling has so much importance. If we do it, we can prevent so many problems which occur due to, like Dr. Seth also mentioned about that, anemia. This is a quite prevalent problem in our country, which is responsible for not only IUGR and preeclampsia, and it is also responsible for a big chunk, which is responsible for to add the morbidity and mortality in PPH also, because even the anemic patient slight bleeding is also responsible for the severe cases. So this is the very important points. And if we do the preconceptional counseling before pregnancy, we can at least counsel the proper diet, proper hygiene, avoiding this alcohol, smoking. Not alcohol is common in our country, smoking, but tobacco is still common, so we can reduce it. And similarly, STD, STI, they are also important, and vaccination. And even our patients, they are not aware of it. They can take any drug in any time, especially in the first trimester, maybe teratogenic. And shifting of teratogenic drug into more safe drug, this all comes into the preconceptional counseling. Problem arise where the patient sometimes they conceive unknowingly and unplanned pregnancy. Sometimes even in the primary patient, they comes in a heavy OPD, ma'am, I want termination. Why? Why you want to termination? Because we have still married 3-4 months back and we want to enjoy life. Or sometimes they say, I want just to pursue in my career, that's why I want MTP. So these things can be avoided by preconceptional counseling. And whenever there is a problem, like Dr. Achla, she focused very well the area which need concentration on that, we can do the selective counseling also, like hereditary disease and hemoglobinopathies or congenital anomaly or something, this type of things which can recur in this. We can include in preconceptional counseling along with the subjective also. So these are the important things. She has done very well, covered all aspects. I should congratulate. I don't want to repeat many things again and again. Definitely her talk was wonderful. Thank you so much. And thank you for giving me opportunity to share this platform. Thank you, Amrita, Sadhana, and my regard to Chandraji madam. And there are so many, Sharda Jain madam, they are quite senior to me. Ragini, she is my colleague. There are so many colleagues also. Thank you. Thank you so much.
Thank you, Chairperson, for the appreciation. Thank you very much.
Thank you to the speaker and experts for their wonderful pearls of wisdom. It's just like well prepared is half the battle won. So if we start with a lot of arms and ammunition in hand, then only we can plan to, win the war. So now over to Dr. Amrita for the start of second session.
Amrita, Dr. Sushma has joined. Our internet is restored. So invite Dr. Sushma Chawla for her address. She has been introduced.
Yes, ma'am. Yes, ma'am.
Yeah,
So,
I was I must
We were
congratulate.
eager to hear you, ma'am. Yes,
I
ma'am.
must
You're welcome.
congratulate for a very, very
Hello?
nice webinar and
Hello?
very important topic. Hello, am I audible?
Yes,
ma'am.
yes.
Just now we talked about that we must do something. So what I say that we should all spread our wings and cover the schools and colleges and even on the students day, so that we can make the parents aware of all these vaccinations. Rubella, maybe thalassemia status we have to know before the girl gets married, and HPV vaccination, and then of course treating anemia and all at the school and college level. Because in the college, when they are going to pass out, they are going to get married after some time. So they are the things which we must have. And I think I must congratulate. It's a very important topic. And I think we should take little time out of our work and go to the colleges, schools, because I'm doing it. And I suggest all of you to do it. So congratulations. And thank you for giving me the opportunity. All the best. Carry on with your subject.
Thank you. Thank you, ma'am. Thank you for your wonderful words and your expert comments on the talk. And now we quickly move on to the second part of the webinar, which is the maternal screening. What next? For this, we have wonderful moderators. And first moderator is Dr. Sadhana Gupta. Dr. Sadhana Gupta is the president of NIGF, and she has been the Vice President FOXI in 2016. She has been the FOXI representative to CEPHOG. Presently, she is the co-chair of CEPHOG NCT committee. And she has also been the FOXI representative to WHO in 2012, way back. And her aim is to strive together for excellence. So achiever of so many awards and papers and presentations, and also a wonderful orator. So ma'am, welcome for this part of the webinar. And our second moderator is Dr. Amita Tripathi, a great organizer, consultant OBGYN from Prayagraj. She is the founder, honorary secretary of ISUPAP, chairperson of WDW Allahabad Medical Association, Prayagraj. She has held many posts, published many papers. She is the invited faculty of too many conferences, and achiever of Vidya Bhasin Award, Kamla Achari Award. And so Amita, you're welcome. And the panelists are Dr. Kiran Chandana, Dr. Aarti Gupta, Dr. Jyoti Agrawal, Dr. Anupma Bahadur, Dr. Kanchan Sharma, Dr. Alok Sharma, and Dr. Sangeeta Pava. So a great panel we have, and a wonderful moderation by Dr. Sadhana Gupta and Dr.
Hello.
Amita. So over to you, ma'am.
Alok, you are audible, Alok.
Okay.
Alok, you are audible. So welcome, we were searching for you. So thank you very much. And this is what we set the vision for NIGF. It is the panel from all states of the North India, and we really look forward to good sharing of experience and what we are doing in practice. So coming after a wonderful talk by Dr. Ashla Batra on preconception care, myself and Amita will be taking to when the patient has come to you on the first visit, then maternal screening, how much is too much and what next. It is that thing, and we will look forward to from all the panel, their inputs, their experience and their way forward for making pregnancy a safe journey for our women. So a little bit background about it, that in pregnancy, the borderline between health and disease is very thin, and we have to keep every pregnant woman under close surveillance. This is very, very important to understood by us as well as by the patient and the family. And what is the modern antenatal care? What Independent India look for? It is a quality continuum care in obstetric, including psychological support that of course begins before conception and extend throughout the postpartum period. We know our country is having a lot of metabolic disorders, and our young generation is not that healthy. And as an obstetrician, we have a great role to play, because child is father of man, and we have a good like knowledge about fetal origin of adult disease. Now, Dr. Achla says preconceptional care, the real clinical experience, real at ground root level, it is very much gaps in it. Unfortunately, in antenatal care also there are a quite gap. We have hours of waiting, crumped up, very, very busy. All public hospital and even a good practitioner have a very, very busy OPD. We quickly examine, quickly write few drugs, few tests, and the patient sometimes really don't get that care what it deserves. It is our Indian data. Still, we are quite, we have much to do. Maternal mortality ranges state-wise difference are quite high. We don't, the neonatal morbidity is also 23 per 1,000 and is still but causes settlement. So there are very, very bridges, many bridges to like gap. So we have to respond to our current challenges and we have to get ready for the future. With this background, it is question to Dr. Kiran and Dr. Alok. When you see patient comes to you at the first visit, how do you screen? It is a clinical screen or it is only a right, you order a number of tests, it is very less or it is very few, or you order only ultrasound, and when you order for this screening or do clinical screening, it is universal or it is something selective. So start from Kiran and then we will have Alok's input. Dr. Kiran Chalna.
Good afternoon, ma'am. Am I audible, ma'am?
Yes, 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 you are audible.
Well, in our clinical practice, we are doing maternal screening, basically on the clinical examination, then with certain tests like hemogram examination, blood group, blood sugar, thyroid investigation, VDRL, HIV, and the Australia antigen, urine complete, ultrasound, etc. And along with this, better investigation we are doing for all the patients, but we are taking proper history of the patient, proper seeing the proper socio-economic status of the patient, drug history, any financial problem of the patient, education of the patient, psycho-social elements, screening is to be done for the patient. And all the factors like domestic violence, sexual abuse, or any multiple partner, failure of contraception, or any disturbance in married life, all these things we take into the account of the patient so as to certain rapport is formed between the doctor and patient, and patient can have faith in the doctor, and generally this we are doing. But the screening part, all the investigation, that higher investigation, we are not doing for all the patients. We are choosing the patient in which we want to do certain investigation, and high investigation we are doing in certain cases only.
So thank you very much. Emphasizing one thing I will like to say, when we see maternal screen, it means a lot of investigation, more corporate, more expensive the thing, and we have the more number of investigation. Thank you, Dr. Kiran, for your wonderful words about the psychosocial screening, which we tend to forget, that the patient is having any support, any birth plan, and that actually makes pregnancy high risk. This is very important, and select, you individualize the screening procedure. Alok, you are in the Himachal Pradesh, you have worked in the very remote areas. What you say about clinical screening, like we have a lot of gestosis prediction about the uterine artery Doppler, very costly, and one is a clinical testing. So your takeaway that, yes.
I'll tell you, like since I belong to Himachal Pradesh, and that too, again, Himachal Pradesh is also emerging. But Madam Kiran has said very good. But to add on, like if we start from the basic, first we have to look for HB only. So we are going for HB to look for anemia. Then we are looking for urine proteins and sugars. That whether then after clinical exam, with the clinical examination, after having pulse and BP and weight of the patient, then we are going for urine proteins and sugar. So everything is seeing that one, anemia is covered, then PIH is covered, then we go for syphilis, then STS we are doing. After that, we are going HIV with syphilis for husband and wife both. Then we are going with HIV, that is husband and wife both. And then we are going for HBs AG, husband and wife both. After that, HCV, again husband and wife both. And blood grouping is to be done to rule out any RH negativity for the patient. And if she is negative, then we are going for blood group of husband. So this is the battery of basic investigations which every Indian woman or every woman in the world has to be screened. After that goes to you are stepping up for again costly investigations, and then we are looking for the previous history of the patient, that what she delivered, whether there were abortions or not, or whether she delivered some congenital malformed baby, or whether in the previous history she had some PIH, GDM, or like that. Then we go for costly investigations like dual markers, or if the aged advance, if she's of aged pregnancy, like post 30 years, or like today is the era of IVF pregnancies and all. So if we are seeing that the patient is high aged group, then we are going for all those markers and all. So these
Thank
things
you,
we are
Alok.
doing.
I think you have emphasized very well this is very important, that our every Indian woman and every woman in the world in the pregnancy, whosoever is having pregnancy, must have this minimal investigation. And we will like to have add on that it is not only the investigative screening, it must be clinical screening as well. Like CVS, many times we really don't put a stethoscope on the patient's heart, and the
Yes.
patient suddenly, when the patient comes in CHF, she is having valvular heart disease. And today I think the people are not tuned to that murmurs and everything, and that clinical skill we have to retain. So thank you very much for a very good foundation. And now see, just say what is the ideal screening test. Why Alok says that we should do this thing, because a screening test must have certain goals. Like it should be health, good, important health problem. It should have the treatment. It should have a good course. It should be a good effective test. It should be acceptable, affordable, and the test should be sensitive. So coming to Amita, you take over this question, please, Amita.
Hello everyone.
Yes,
So
Amita,
moving,
yes.
पूछूं मैं आपसे
हाँ,
सिंगल क्वेश्चन मैं साधना जी मैं ये पूछना चाह रही हूँ, हाउ मेनी ऑफ अस आर डूइंग द
आज
टेस्ट?
तुमको जवाब देना है अभी. You are supposed to give answer, not to ask question. We will take it over. So Amita,
Yes.
the next question from your
so
side.
hello everyone. So moving towards at first antenatal visit, what test you order in your practice? Your screening criteria is driven from the professional body recommendation or your clinical experience or the epidemiological spectrum of disease in that area. So Dr. Aarti and Dr. Jyoti, anyone can take.
Ma'am, basically, whenever we are doing the test, we should have all the three things in our mind. We should have some documented professional criteria and our experience also. So all the three things we take together. And the first test which we want to go is the CBC. CBC ke baad, then we will go for the blood group, blood sugar random, HIV, Australia antigen, hepatitis C, serum TSH और यूरिन कंप्लीट. इसके अलावा मैम ये बेसिक टेस्ट हमारे फर्स्ट उस पे यही होते हैं तो इनिशियली हम ये टेस्ट कराते हैं. यदि पेशेंट का हीमोग्लोबिन हमको कम मिलता है या एमसीवी और एससी
Abhi Aarti, we will go. So this is your basic test. So Jyoti, Dr. Jyoti, your input, what Aarti says, it is your experience or it is professional body says.
Besides all that, a very good afternoon to all of you. First of all, I would like to thank the organizers and Dr. Sadhana Gupta to making me a part of this prestigious CME. We have all discussed the investigations, the blood investigations and everything. But here I would like to just emphasize that we usually forget to do the urine culture sensitivity. In my clinic, besides the urine routine and the microscopy, I am sending it for urine culture also at the first visit itself. And that's a part of an examination also, that put a speculum and take this opportunity to do a pap smear also. Many a times the patient is scared and the relatives are scared, nahi pap smear karne se bleeding ho jayegi, threatened abortion ho jayega. Even the doctors are scared what to talk about the patients. So here I would like to take this opportunity that you should screen the cervix as well in the first visit itself. And since GDM is becoming very common, we should utilize this first visit to do the DIPSI 75-gram glucose test.
We will come to it. We will come to intricacies.
Yes.
Okay, so it is a background. And now coming to, thank you Jyoti for your input, emphasizing urine culture. That is very important, and at least per speculum examination of the cervix. So Jyoti, you have really added, and Aarti, you are really put what we are doing in the real clinical practice. So screen test positive. Now we have based this foundation that we do this test, a little variation in different panel what they want to do, but what next actually when it comes positive, why it is important. So Amita, you take the question so that we circulate that. Yes.
We have a woman, she's primary gravida for the routine antenatal investigation, came to be hepatitis B positive. For the husband, he is hepatitis B negative. So they are serodiscordant couple. So how do you manage antenatal and neonatal care in this patient? And would you like to have any further test or examination? Would you like to refer this patient to hepatologist or gastroenterologist? Or what about husband and family management counseling and plan for delivery? So why the hepatitis B screen is so important and how do you manage in such situation? I think Dr. Anupma will like to answer this question.
Good evening, everyone. At the onset, I'd like to thank Dr. Sharda ma'am and Dr. Sadhna for giving me the opportunity to be a part of this prestigious panel of North India Gynae Forum. Now, as far as hepatitis B is concerned, there is a vertical transmission of hepatitis B from the mother to the fetus. Therefore, it is very important to screen for hepatitis B during pregnancy. Now, if suppose she is hepatitis B positive, we need to do her hepatitis B DNA viral load or her HBe antigen and assess for cirrhosis. If HBV DNA is less than 2 lakh international units ml or HBe negative without cirrhosis, then there is no need for any for giving any prophylaxis to the mother. But if her HPV DNA is more than 2 lakh copies, I mean international units per ml, or she is hepatitis HBe antigen positive, then we need to start the mother on tenofovir prophylaxis from 28 weeks onwards till the birth of the baby, and then reassess the mother for maternal tenofovir treatment after her delivery and monitor as per the WHO guidelines. Suppose there is presence of cirrhosis or HPV DNA more than 2 lakh, more than 20,000 international units per ml, and there is persistently abnormal liver function test, then she needs to be started on long-term tenofovir treatment and she needs to be monitored as per the guidelines. As far as the neonate is concerned, as soon
we will
as
come to it. I think Anupama, we will just sum up very brilliant message about it. Why we need hepatitis B, because a lot of reservoir of infection is like from mother to child, and child is having hepatitis B, and then it is causing the horizontal transmission. So this is very important that the hepatitis B screening should be there in obstetrical population. And secondly, you have rightly said that we have to keep when hepatitis B positive, why we took this question, but actually we know so many things. But when the patient test become positive, many practitioners say, no, don't deliver in my institution, you go into medical college. So very rightly said that you do the viral load. Anti-HBe antigen positivity is also taken as a surrogate marker. That I'm saying we are emphasizing it because in sometime we don't have that facility or the quick assessment, then you should do the HBe antigen. It also tells about infectivity. Like if you are a good setup, then you can really have a hepatitis B cesarean positive patient delivery easily with universal precaution. And you must know that how it is infectivity to professional as well as the infectivity to the mother to child transmission. So an important thing is we know many things, but in clinical practice, when it is hepatitis B positive, then what is the roadmap of that delivery? How we have to counsel the mother and family, that is very important. A very important message is that when there is hepatitis B, though husband is negative, ask for safe sexual practices. Secondly, vaccinate a husband. Never forget that you are only for the pregnant woman, and screen all members of the family for the hepatitis B screening, and if they are negative, get them vaccinated, and you have to see. So it is one opportunity and one test which has got a positive repercussion on the whole health of the mother and the husband and the family. So this is what a positive antenatal care. So Kanchan, we like to have your input when you have this hepatitis B positive, what you tell to patient about neonatal care, because she might come to you or she might come to any other place or in PSC. So what you tell about this thing about the neonatal care? Kanchan, your input.
Thank you, madam. First of all, my regards to Dr. Chandravati madam, Dr. Sharda Jain madam, and to you to make me a part and give me a chance in this wonderful panel. Madam, questions have been wisely devised. Thank you for this question. As already told wonderfully by Dr. Anupama, that there is a vertical transfer also that you have also explained. So in this case, most important is the counseling of the patient, of the relative, and all whole of the family. We will tell them the importance why we have to take an extra precaution of this particular patient, because there is a transfer from mother to the fetus that may happen in case that happens in a particular setup, that is in your setup or any other setup. You should have a separate room for it, and the spread from patient to other is also very important. You should wear the tell the patient that we have to take full aseptic precaution, wear full dress as it is important in OT, cover your eyes and wear double gloves, and tell the patient whole of the
so universal bulk precaution is the thing. Universal. One
That
thing,
is very
Kanchan,
important.
you refer the patient. One question, little specific. One question, you refer to the hepatologist or the like a gastro people, or you are feel that you can deal with it by taking this thing, viral load and hepatitis B antigen. Do you prescribe antiviral drug, that is tenofovir, or you refer to like hepatologist or the gastro people?
This is also very important to have a teamwork. Although I know I have all the knowledge about that, we have to do the viral load, etc. But to my gastro friend, I always, Dr. Gaurav Chawla is here, that I always refer to him and say the patient to take his opinion, so that at least the responsibility should be shared, and according to his guidance, like that, how much is the viral load and can we go with this, and or we have to start this antiviral that is to be suggested by my gastro friend. That
so
is very
one thing is very important, that as an obstetrician, we also emphasize, because we are concerned about mother to child transmission. So if viral load is high, that is 5.3 lakh log per unit, but WHO is also, we are having a different like international standard, and that also makes the thing confusing. Then to reduce maternal to child transmission, we should prescribe the tenofovir, which is considered drug of choice, that should be started at 28 to 32 week of pregnancy and start 4 weeks after delivery. So yes, we refer to hepatologist or the gastro patient, but actually the obstetrical concern, sometimes we have to teach them that it is important for the prevent maternal to child transmission. This is very important, and the tenofovir is the considered the drug of choice because of the very low resistance and a quite rate of safety. So Sangeeta, now we come to any neonatal issue, what we want to say. Sangeeta Pava is a special question, neonatal consideration.
Yes,
because
ma'am.
you
Good
have
evening.
to counseling. Yes.
Good evening to one and all, and thank you, Sadhna ma'am, for inviting me on this platform. I want to add on the previous question also, that HBE antigen should be done at 36 weeks of gestation. In each and every patient who is Australia antigen positive, HBE should be done at least at 36 weeks of gestation. Yes, there are neonatal issues. Family counseling is very, very important, because we are concerned about the husband as well as the caregivers also, and there is vertical transmission that is too high, and globally neonatal hepatitis is very, very high. When patient is infected in the first trimester, chances are 20%, but when mother is getting infected in the third trimester, it is approximately 80% chances. and they should be counseled. Family should be told that if vertical transmission is occurring, chances of chronic carriers is approximately 80 to 90%, which is later on leading to the cirrhosis and hepatocellular carcinoma, instead of the horizontal transmission, which occurs after 1 year, when chances of chronic carriers and hepatocellular carcinoma is very less, that is approximately 10 to 20%. And family should be counseled about that baby should get hepatitis B immunoglobulins at birth, that is active immunization, as well as vaccination, that is passive hepatitis B vaccination within 12 hours of birth, which reduces vertical transmission from 85 to 95%, but still there is chances that 10% of the chances that baby will get infected. So family should be counseled about all the aspects, about all the active and passive immunization, what is the risk and what is the risk of the chronic carriers and hepatocellular carcinoma. That's why universal screening
Thank you,
is
Sangeeta. You were brilliant. So my takeaway, what all the panelists says, that a counsel, because patient might not come at your place for delivery. तो उसको बताना होगा कि बच्चा जैसे ही पैदा होगा 12 से 24 घंटे में उसको एक महंगा वाला टीका लगेगा, because आप उसको बहुत स्टैटिस्टिक्स बताएंगे तो उसको नहीं समझ में आएगा. But the baby is there, then they are receptive कि उसको टीका लगेगा और उसके बाद हेपेटाइटिस बी का पूरा टीका उसी तरह से लगेगा और 9 महीने से 1-1.5 साल के बाद से द बेबी हैज टू बी टेस्टेड फॉर हेपेटाइटिस बी. क्योंकि हम लोग रूरल लोगों को अनएजुकेटेड बहुत सारे डाइवर्स स्पेक्ट्रम को हम लोग डील करते हैं और हमको उनकी भाषा में बताना होगा कि उस बच्चे को डिलीवरी के समय क्या करना है और उस बच्चे को किस तरह से पीडियाट्रिक केयर में रखना है. एंड वी विल लाइक टू एम्फसाइज दैट इवन डिस्पाइट ऑल इन्वेस्टिगेशन और वैक्सीनेशन 1 to 4% of the children, what we say, the escape phenomena, and the baby has to be treated like investigated for the hepatitis B positivity. So thank you very much. So Alok, आपने कहा था कि hepatitis C is the basic right for all, like all pregnant patients should be screened for hepatitis C. So you are already dealing with it. So the professional bodies are not in that way. Professional bodies actually do not recommend hepatitis C screening. So what's your takeaway, Alok, for it? You are the universal or it is something specific risk cases? Yes,
no,
Alok.
we are doing here in Himachal Pradesh as a universal screening for hepatitis C also, madam.
Any difference of opinion? So Alok is already on the thing.
We are also doing each and every patient. Yes, ma'am.
So
but there are no recommendations, but we are doing.
Yes, so hepatitis C is till now what professional body says it is for unexplained chronic liver disease, people with STD, affected partner, drug usage. But now the American Infective Society and the Hepatologists Association recommend that there should be universal screening. So professional body doesn't say, but we have to take it like we can do it if it is whenever it is doable or you think it is feasible. So Kiran, Dr. Kiran and Aarti, अभी सभी ने कहा VDRL करते हैं और लोग कहते हैं कि अरे अब इसको छोड़ देना चाहिए, अभी कुछ इसमें है नहीं. So what is your takeaway, Dr. Kiran? VDRL आपको कितना पॉजिटिव निकलता है? जब वो वीकली पॉजिटिव आता है, then what you do next? And this the penicillin, which is drug of choice, is it available in your setting? So Dr. Kiran and Dr. Aarti.
Yes, ma'am. Yes, ma'am. But previously, in the early days of our practice, we were getting a lot of cases of syphilis. But all of a sudden, due to certain precautionary measures, antibiotics, and education of the patient, the number was limited. But in the recent time, I have seen few patients they have got the VDRL positive, maybe because of multiple partners or some drug abuse or any multiple sexual partners. I have observed during recent days of my practice. And if the VDRL is weakly positive, I will like to repeat the test. Or sometimes the VDRL test is false positive or false negative also due to certain other diseases also. Or I will do the RPR test or TPPA test or FTA antibodies test for confirming the test. FTA antibody test, it does the 100%, it confirms the diagnosis. And if the patient is positive, then I will do the titration serological test of the testing. Or for treatment purpose, I will like to give patient benzathine penicillin for every weekly to be given for 3 weeks, or procaine penicillin to be given for say 14 to 20 days as recommended. And the baby is to be also, if the patient and the if the patient is tested in the first trimester, we should repeat this test, serological test at 28 weeks, at 36 weeks, even after delivery also, and we should test the baby also for this RPL, and this test should be done till this test is negative, and it should be repeated in the baby also, fetus also.
So, Aarti, what is your input? Dr. Kiran has wonderfully said that it is on the rise because globally the people are now concerned there is a resurgence of syphilis, and we have to keep this test as a screening test because there is a maternal to child transmission of syphilis is quite long. Once mother is infected, she can transmit to a long period. So, Aarti, your input penicillin sometimes we don't get now. So, how do you treat Aarti? You do for alternative drug.
And this is the biggest problem. There is not even a single doctor in the Agra who is giving the penicillin to the patient. I have recently 2-3 patients VDRL positive, and I referred them to every place. There is none of the doctor, even the skin specialist, even in the SN Medical College, no one is ready to give the penicillin. Then I have no alternate other than giving the substitute for the penicillin. So that is the one problem. And the second thing is this: you are very right. VDRL is again emerging. Because in the beach, ma'am, I thought that I should stop to do the VDRL. But recently,
so don't stop.
I haven't stopped. In last 6 months, I have 5-6 patients of VDRL, and it's very important to confirm the VDRL with TPHA, Treponema pallidum heat agglutination test to confirm is it really positive or not. This is very important. And second thing is this: the another drugs which I have used, I have no other choice to give. It may be azithromycin, maybe doxycycline. Doxycycline, ma'am, 14 days के लिए देने में pregnancy में
doxycycline is contraindicated in pregnancy.
So that I cannot give. I have given the azithromycin and moxicillin. These are the 2 drugs which I have given during the pregnancy, nothing else, and that too we should give for the 14 days. और उसके बाद में मेरे पास कोई ट्रीटमेंट नहीं है, मैंने पेशेंट को छोड़ दिया.
Thank you very much coming, Aarti. We really like your honesty in panel, and that really brings life. So the alternative drug is
Aarti ma'am has rightly said. Recently, we have also faced this problem. Even in the medical college, when I refer to the medicine people, they said go for the skin department opinion.
Penicillin is not available. Actually, pharma people is not manufacturing penicillin.
Yes.
It is not about doctors.
Oh,
so
alternative
drugs, we want to give, we have only 15 minutes left, a lot of things to discuss. So we will be very brief and concise. So erythromycin, 500 milligram QID, azithromycin 2 gram once daily, and ceftriaxone 1 gram intramuscular OD for 10 to 40 days. For all the audience who is with us and we are having difficulty in penicillin, then these are the drug of second choice, and always watch baby also, because we do screen because for the neonatal benefit. I think urine culture, Dr. Kanchan, your quick comment. I think Jyoti, you have taken this question, Jyoti, that you are doing UTI.
Actually,
Madam,
yes. Madam, actually, considering UTI, which is very important in pregnancy, because that may lead to premature contraction of the uterus and infection to.
So, what's your message? It is simple
so
urine.
my message
urine
is ideally
urine culture.
We should counsel and keep in our mind that we should do screen for urine culture in each and every patient, and at least we suggest the patient. Many times the patients are not agreed because of the cost. We at least do urine routine and microscopic and keep all the symptoms in our mind, and may try to do in almost all the patients. That is my message.
So one thing I will say, don't may do urine culture because of complications are much higher. It is IUGR, it is preterm labor, it is maternal pyelonephritis and the chronic kidney disease. So do urine culture at the first visit. Treat asymptomatic bacteriuria, very, very important, till the culture is negative, and repeat it till the culture is negative. So UTI screening and the treatment of the asymptomatic as well as symptomatic bacteria is very small step which have a long-term the effect on the positive obstetrical outcome. So very, very important, a good message. So Anita, you please go for the GDM. We will be quick because we will be binding within 15 minutes.
I just wanted to add one thing. We should repeat this urine culture even in the 3rd trimester, even if the patient does not have any symptoms. So we
thank you very much. because sometimes patient comes with the pain, with the mild discharge, and you see it is urine culture, backache due to urine infection. So it is very important that you repeat it in the third trimester. Thank you, Jyoti, for it. So Amita, you take over. We will be very quick. How to, Amita, you take over. Yes.
Our country is becoming slowly and slowly diabetic capital of world. So glucose challenge test for GDM is very important. And what is your take that you all do? I think we all do universal, whether you are universal for testing for GDM or selective. Dr. Anupma, you want to tell?
Yes, ma'am. Ma'am, we are doing universal screening and not selective screening. It implies a screening of the entire population or subgroup, irrespective of the risk factors. So be it ACOG, be it American Diabetes Association, IADPSG, or even DIPSI, they all support universal screening. And this is because selective screening would miss out on 20% of GDM cases as compared to universal screening in India. So also, since the Indian population, we are a high-risk population for GDM. Plus, there is an 11-fold increased risk of developing glucose intolerance in pregnancy as compared to the Caucasian group. Therefore, it is important that we do
so
a
how
universal
you do?
screening.
So we are all agree to it, and we will say DIPSI we will take first, because the American Association, they have not that incidence. So DIPSI recommendation. So how do? You DIPSI test? You do what? 100 gram OGTT,
Ma'am, we do a
75
grams OGTT, and normally what we do is that if there are risk factors, that is BMI more than 30 kilogram per meter squared, or there is a previous macrosomic baby, or that is weighing more than 4.5 kg, previous history of stillbirth or an anomalous baby, or previous history of GDM, family history of diabetes, plus we are a high risk ethnic group for diabetes. Also, if there is a high history of polycystic ovaries, then we do it in the...
So we are doing universal. So thank you very much. First of all, universal is the message, and always do the glucose challenge test, not the postnatal. Jyoti, your comment about this thing, why we want to, आप इसको 16 to 20 week पे करेंगे या first visit पे करेंगे? Why it is important to do at first visit, though it differentiate between overt and the pre-existing diabetes mellitus and the GDM which have developed to it.
So I would like to do it in the first visit, in the first trimester, whenever the patient comes. And the most important thing is it is a single step test. Whether the patient is fasting or not fasting, just give her a 75 gram glucose load and take a venous sample 2 hours later. And the cutoff values is taken as 140. Why I stress that it should be done at the first visit itself, because earlier the diagnosis, better the treatment, and much better is the outcome. Because jitni jaldi control karenge, utna acha hoga. See, the fetal pancreas starts developing at 10 to 11 weeks of pregnancy. So if we postpone it till the second trimester, then already the fetal pancreas has started working, and then we will miss out. Then the things become very complicated, like macrosomia and IUD and all those things. So earlier we start, better is the prognosis for both mother, baby, and the long-term implications.
Thank you, Jyoti and Anupama, about it, because when we detect the impaired glucose tolerance in first trimester, then it may be pre-existing diabetes. Yes. And when it is been pre-existing, then there is a more risk of congenital malformation, maternal complication, and we need stricter control of blood sugar level. So this is message that the professional body say do it around 16 to 20 week, then 24 to 28 week, and if it is high risk, then again repeat at 36 week. But if it is, you have detected impaired glucose tolerance in first trimester, then be careful that this patient was having the diabetes before it, and that fetus and the mother has to be followed up very carefully. So we will not go what next, because maternal nutritional therapy and the pharmaco treatment, when the maternal nutritional therapy is not able to control the blood sugar. So coming to Sangeeta and Kanchan, T3, T4, TSH screening, we all agree that we should do the thyroid screening. But yes, what you do by TSH or by all T4, T3, TPO, what you do in your clinical practice? Yes.
First is that
Yes.
TSH, if TSH is normal, patient is euthyroid. If
Yes.
TSH is higher, according to the trimester wise, in the first trimester, higher limit, upper limit is 2.5, second trimester 3, third trimester again it is 3. When it is above the normal range, then free T4 and TP antibodies are done. If T4 is normal but TSH is still high, it is subclinical hypothyroidism, and then we will go for the TPO antibodies. If they are positive, then we will treat her with the levothyroxine. And if free T4 is less and TSH is high, then it is overt hypothyroidism. Then we will go for the treatment with the thyroxine. And after 4 to 6 weeks, it is again repeated. And then
So one message is universal. Kanchan, when you want to do TPO antibody titer, when you do in all or in selective patient, any comment about it? Antibody titer, क्योंकि बहुत लोगों को confusion होता है क्या करना चाहिए.
In
But
all,
one
we are
message
not
that
doing.
is same,
We are
all
not
is
doing.
same. We are not doing.
We are not doing in all. In case of that is a precious pregnancy, in case we are doing some ART or previous history of Hashimoto disease, etc., then we are doing TPO antibody.
So a clear message to all audience: when we want to do TPO antibody titer, personal history of thyroid and the other autoimmune disease like diabetes, patient with recurrent pregnancy loss or preterm delivery, women with goiter, and the disorder or family history of thyroid disease. So TSH for all for screening and TPO antibody titer when there is a elevated TSH and the associated condition, and when the patient is having TPO antibody positive, these patient has to be followed for the thyroid dysfunction, for the postpartum thyroiditis and other disorder. So thyroxine supplementation we will be taking. I think it has been covered. We want to have the 30% increase, that 25 to 50 if it is less than 2.5 in first trimester, and if it is more than 3, then we have to increase like accordingly, and if it is less than 0.1, then you have to reduce the dose. So it is all what next. Anemia, I think we have covered a lot. Hemoglobin. Quick comment from Dr. Kiran and Dr. Aarti, and if we are missing one panel question, how do you screen for hemoglobinopathy in your clinical practice? So Dr. Kiran, for you. We will be winding in 10 minutes, 5 or 10 minutes, yes.
If the patient is having microcytic, and if the patient, we are doing hemogram, if the patient is not is having persistent low hemoglobin, in that patient we are suspecting if the patient is having thalassemia or it is just microcytic anemia. In those patients, we do the serum iron level or serum ferritin level or total iron binding capacity, or we do the HbA1c level to see the thalassemia. If the patient is having microcytic anemia and the serum iron level is fine, is within the limit, and the Menser index is less than 13, then we suspect the thalassemia. Otherwise, it is iron deficiency anemia.
Thank you very much. Aarti, your comment about it. What do you do in your clinical practice, Aarti? Aarti, you are there or not? So one good message that read CBC, ABC or CBC. So Aarti, क्या करते हैं आप yes clinical practice में?
Yes. I want to say whenever my patient is having less hemoglobin, around 8 gram percent के आसपास, और that was not increased by the oral iron or injectable iron, then I used to go for the electrophoresis. And in most of the patients जिसमें कि hemoglobin नहीं बढ़ रहा होता है, उसमें electrophoresis में या तो मुझे most of the time I got the thalassemia. Not in all patients, but in few patients I will used to get the thalassemia. Then I have to treat these patients by the blood donation because it will not be raised by the hemoglobin. And the most important message here is this: we are not supposed to give iron one after another if the patient is not getting increased hemoglobin by one preparation. Then we should go for the electrophoresis. We should test the patient, and then we should diagnose the thalassemia.
So very, very important message that if we are not able to do the HB electrophoresis for all, then be careful to read ABC of CBC. If MCV is less than 80 FL and MCH is less than 27, then consider that this patient can be having hemoglobinopathy. And secondly, what message? Don't give IV iron before like confirming that it is the patient is having immunopathy, because that can cause damage to the patient. You cannot overload the patient with the iron. So whenever you can give oral iron, it is not responding, then you consider that the patient may be having immunopathy. So very important message, read CBC of ABC and the Medger index, it is less than 13, then you can suspect the immunopathy. So this is very important. I think we have covered it very, very well. HIV screening, we can, Jyoti and Anupama, your quick comment about the HIV screening. अगर ये positive आता है तो आप क्या करते हैं patient को?
HIV screening we are offering.
Anupama, you are there? Anupama, yes. Anupama and Jyoti. Yes, Jyoti.
Yes, we are offering universal screening for HIV with a consent, because she may opt out also. But so far, none of them has done so far. And in case she becomes positive, the first and the foremost message is don't be panic. ये नहीं बोलना अब मैं क्या करूं, because we have to, as a clinician, I should not be panic. I should take care of the staff and all the caregivers, and as well as the patient and the family, because everybody is panic. Here I would like to say, all the brave gynecologists who have gone through the COVID period and managed pregnancies in COVID period, अब HIV उसके सामने थोड़ा छोटा हो गया. And the second thing is, termination is not the answer for the HIV pregnant patient, and the fast diagnosis and a fast treatment with antiretroviral therapy is the key in managing an HIV patient, because our aim is to have a healthy and a HIV negative baby.
So thank you very much, Jyoti. First of all, no, don't panic, prepare a road plan. And thirdly, irrespective of CD4 count, every pregnant woman needs the antiretroviral therapy. Yes. That is very, very important, and we have to do for all neonates and the this thing. So we are coming to end of the panel. Anupama, you are there, Anupama Bahadur. So you have taken, I think already, Jyoti, you have taken that you do perispectrum examination. Sangeeta, your comment about pap smear,
yes,
why we are confused about it. You do it or you don't do it? You do it?
I do, because I have given the thesis on that pap smear during antenatal period.
Even I do the perispectrum examination at least in each and every pregnant patient. That should be a naked eye examination. Why is very simple. If you have any doubt in your mind, you can just do the staining with the acetic acid and see by the naked eye.
Perispectrum examination, you can find trichomonal discharge, you can find candidal discharge, you can find erosion, and you can find the unhealthy cervix.
With VIK, false positive results are very high during pregnancy because of the squamous metaplasia, and this is because of the hormonal influence. So I think we should go for the cytology.
Actually, see for the S2 you can see for the S2 areas.
So,
and
so thank you very much. I think Sangeeta mentioned and everybody's message, don't despair. Abhi to patient also don't want to get perispectrum examination, so be brave. You can handle HIV, you can handle this thing COVID, and you should be brave enough to do PS examination, because we are targeting for the elimination of cancer cervix. Pregnant population is a very good time where we can do the opportunistic screening, and this all matter has been taken by Dr. Amita Tripathi for this, that we have the fear, but we have to increase awareness about pap smear. So we will don't go for 2 or 3 minutes. Torch screening, rubella screening, कहीं पे लोग बहुत करते हैं. So Alok and Dr. Kiran, what's your takeaway? Anupama, you are there or not? Because we have missed 1 or 2 questions. Final takeaway about the rubella screening, what we say. We will don't go.
Ma'am, I'm here only.
Yes, Anupama, you are coming. Yes, Anupama, you are doing rubella screening or?
Ma'am, ideally it should be done, but we are not doing it as a routine.
You are not.
Ma'am, even we are also not doing, ma'am, for any routine purposes. Only with, so like that during the patients with IUGR, then we go for we have to see the reason. Then only we are going for doing this torch examination. Otherwise, we are not.
So nobody is doing, I think, rubella screening, but we see a lot of prescription, and the patient has been advised RBAC when IgG is positive. So be careful. It is preconceptional care when we have to search for the rubella vaccination. And the second thing is when we have some problem in the baby and then we go back that this can be the torch infection. So rubella vaccination, and we have to be a good dealing. We will take another torch. So we are something. And the last comment about newborn screening, again for Anupama, you are in the teaching institution. Newborn screening का आप क्या future देख रहे हैं इंडिया में, independent इंडिया में? Last comment and we are summing up.
Ma'am, in our institute, we are doing newborn screening only for congenital hypothyroidism because we belong to the Himalayan belt. So where there is iodine deficiency, but otherwise in states like Goa, in states like
actually,
Chandigarh,
ma'am, we are doing for hearing screening, that is DPOAE testing. Every newborn baby is universal hearing screening is done in our institute. That is acoustic emission testing.
Yes. So you are doing hearing, and Anupama is advocating, and rightly, for the congenital hypothyroidism. These two things are very, very important. Alok, you are also in teaching institution. Any program for the newborn screening?
No, ma'am, we are not doing, ma'am.
Doing, and it is a way forward. I think as a professional, we have to have that advocacy for the newborn screening program, and it is required a complex integrated clinical services. It is not a lab test. It is a system. Then we have to recall, we have to confirm diagnosis, we have to do something for the baby and the family. It is not a lab test, which we want to emphasize, and rightly said, congenital hypothyroidism. So finally, thank you very much for the great expert inputs. Thank you. Medicine of future focus on prevention. So prevent, preventable, screen with wisdom and knowledge, interpret well and manage well, not only mother but the newborn. Thank you very much. And with this, I seek everybody's support for my candidature for Foxy presidential candidate. Thank you. Always stay connected, and we are just in time, I think. And wonderful inputs from the all panel, and thank you, Amita, for being together in all moderation. And we were a little quick and could omit, so thank you very much. Pooja, you can take over the next session for the award-winning session for the digital something for this digital certification handholding to the winners. So.
Thank you, ma'am. Thank you so much.
Thank you, ma'am.
Before that, I would just request Dr. Sharda ma'am to present her inputs regarding the whole NIGF meet today.
I think the meet was great, but your past time, 15 minutes, which should not happen. And you are still going to take another 5 minutes as far as the declaration is concerned. In a scientific meeting, we should be like a Western people, that the time to be start is, we should be very particular, and time to stop also we should be particular. And I think, I definitely enjoy these meetings because I come to know so many people, and when they speak their mind, I think I am absolutely impressed. I think this is what I can definitely say, that not only you know the personality, but you also know what is the brain behind them. So I really thoroughly enjoy from the beginning till the end. Myself and Dr. Shushma Chawla is here. So definitely shows that we are definitely following everything is there. At this particular, yes, sir.
Sharda ma'am.
Yes.
This is Dr. Alok Sharma from Shimla, ma'am.
Yes, I duly recognize you, and I definitely appreciate your things that you will definitely unite Himachal in this particular group. So I will be very grateful. Sure. And I will definitely tell you that many people say that I have started this particular forum, but I think the main persons who are behind it are Dr. Ragini Agarwal and Dr. Sadhana Gupta. I think they have taken an initiative. I only started, the things. But I think the initiators are these two people.
Thank you so much, ma'am.
Right, sir.
Dr. Mala Srivastavici here, because we would like to have her inputs also regarding the webinar. Since Dr. Mala does not seem to be here, we would quickly just go on to the digital e-certification distribution. The Dr. Ragini will be presenting the first certificate e-slogan competition which we had for the Independence Day. Dr. Ragini is the president of Haryana Obs and Gynae Society and the president-elect of NIGF. And the first prize goes to Dr. Sumita Verma. Please flash that. Dr. Sunita Verma, she participated and was declared the winner in first prize of Independence Day slogan competition.
So Ragini, you please Ragini, are you here?
Yeah, I can hear. I'm
Yes.
there.
Yes, Dr. Sumita Verma, first award winner is there. Congratulations. Dr. Jaya is there. Dr. Jaya, your input and please, Pooja. Dr. Ragini, are you here? Ragini to be present to give this thing. Sumita, yes.
Dr. Ragini, you're supposed to announce that Dr. Sumita is the first prize winner of the e-slogan competition.
Am I audible?
Yes. Yes, Dr. Sumita.
Thank you so much. I'm so happy I got this first prize. This has really boosted my confidence, and I'm very grateful to the organizers. And I hope we will remain connected. And the confidence of all the, because I belong to a very small city and now important Ayodhya. So it has really
now
boosted my
important. It
confidence.
had always been important, ma'am.
Yes.
Ayodhya is like very, very important. Dr. Amrit Pal Kaur, ma'am,
Dr. Jaya is with us. Dr. Jaya is with us. Dr. Achla Batra is with us. Yes, two vice
Dr. Jaya, the second prize winner, please announce Dr. Niharika's name and her input. Dr. Jaya Chitam.
Dr. Alok, please mute yourself.
Dr. Jaya, please, can we have your input and please announce the winner of the e-certificate competition of the Independence Day? I don't think Dr.
Hello.
Jaya is also.
Yeah.
Are you able to see me?
Yes.
So the second prize winner is Dr. Niharika Malhotra. She's from Agra. So clap for her. And wonderful slogans we read from all the winners. So congratulations to all.
Thank you.
Dr. Achla, you can announce the third, Dr. Achla, ma'am?
Yeah.
The prize for the third winner or third prize winner of the slogan competition.
Where is she from?
Dr. Rita Malik, I don't know where.
She's from Delhi, I think. Delhi.
Okay. So Dr. Rita Malik is the third prize winner for the slogan competition. And this competition is just to bring the creativity out of the doctors who are working day in and out. And they are so creative, but it remains buried in them. And when we have competitions like this, when we get to see this another facet of our colleagues. So congratulations, Rita Malik, for winning the prize for this Independence Day slogan competition.
I'll just quickly enlist the 4th till 10th names of the slogan competitions. 4th is Dr. Manju Sharma. 5th is Dr. Ankita Nigam. 6th is Dr. Aradhana Singh. 7th is Dr. Suparna Grover. 8th is Dr. Manjusha Goyal. 9th is Dr. Nayantara Lucian. And 10th is Dr. Neena Tripathi. Congratulations to all the winners who participated in this slogan competition and made it a huge success. It was the first time that it was held in the NIGF, and I hope that more and more of these activities we will be taking up in future. So these are the slides, and these are the slogan winner.
Next.
Yeah, this is
next
next question. Yeah.
Next.
This is by Dr. Rita.
New Delhi Science, yes. And 4th
Better
and
just to read
Dr.
them.
Yes, she has made, Dr. Manju Sharma has, it's rest we have made, but Dr. Manju has given this beautiful design to our poster. So thank you.
It is in
Dr.
tricolor
Manju.
also.
Yes.
So now vote of thanks by Dr. Amrita.
Thank you, Dr. Pooja. And with all my respects and reverence, I'm here to give the word of thanks. And at the outset, I'll thank the chief guests, Dr. Chandravati and Dr. Sushma Chawla. Although they are a part of us, but they were here to give their blessings. And thanks to Sharda Jain ma'am for forming this body in IGF. Thanks to you, Sadhana ma'am, for being our leader and giving me the opportunity to do this webinar, to conduct this webinar. And I got introduced to so many wonderful people of our part of the country. And thanks, Achla Batra ma'am, for a wonderful talk and giving us a checklist of question and answers and seeing the patient properly for the preconception care. Our experts, Dr. Shyam Pyari, who gave the idea of shifting the drug from from the teratogenic one to the non-teratogenic one. Dr. Vidhu rightly brought up the talk of point of anemia correction in adolescence, and Dr. Kishore, who talked about the dental care part. So it was indeed a great talk, and thanks to the experts and the speaker. And the second part was very, very exciting with all the inputs and the questions from the moderators, Dr. Sadhana Gupta ma'am and Dr. Amita Tripathi. And the panelists did a great job by giving their inputs. Dr. Kiran Channa, thank you. Dr. Aarti Gupta, thank you. Dr. Jyoti Agrawal, Dr. Anupma Bahadur, Dr. Kanchan Sharma, Dr. Sangeeta, and Dr. Alok Sharma. Thanks to all of you. And also thanks to all the attendees who were here and gave us their precious time and made our effort worthwhile. Thanks to Core Connect team who are there and gave us a wonderful platform and a seamless program. So thank you all and a very good night. And I'm sorry if I have left someone. I'm sorry. Thank you so much.
Madam, we are just at 6 p.m. We are right in time. We have not crossed a single minute. I always say to all experts, Madam is very strict. We will finish in time. So it is right. It is 3 minutes left.
Yes.
My
last part.
We can have a good group photograph in those 3 minutes.
Yes,
put their videos on. And my request to each and everybody is that, please see to it that the membership increases. TTK space se chal rahi hai. I think, you should see to it that every day in your group, 10 people enroll in this.
Yeah, we do it.
So I think my sincere request to everybody, please walk the talk. Walk the talk.
Alok, your responsibility in Himachal Pradesh to make societies and make an IGF. And everybody,
Sure.
yes, our all sincere request, myself, Ragini, Dr. Sharda, and everybody's Dr. Achla, all office bearer. Please, it is simple filling of Google form. It is nothing extra. Just we have to be there today and connected and united for all the future vision and for service and unity. So
I'll take care, ma'am, for Himachal Pradesh.
Yes. So we take
And may I say something, ma'am?
Yes.
Let's all join together for sadhana, ma'am.
Yes. I think,
Yes, ma'am.
these meetings are only meant for it that you should not forget that your presidential candidate for Proxy is Sadhana Gupta.